this system we'll talk about the kidney, one of the most important system of the systemic pathology, renal system. So we'll first start with the urine microscopy. As you see this urine microscopy, these are all the RBCs, this RBC, this again is RBC, okay, this is RBC, okay, and now this is actually again an RBC, okay. Now the large one here, you see the large one here is a epithelial cell, this is an epithelial cell, okay. Sometimes you can see a pus cell, as you see this one is a pus cell, okay, and these are the crystals, the crystals that you see here. This is what you see in a urine routine microscopy. Sometimes apart from this you expect the casts. So what are casts? A formed element with a unique shape and size is called as cast. In this image you can see first of all that is a hyaline cast, this is a granular cast, this one is a WBC cast, and you can see this has a RBC inside it and hence becomes a RBC cast. You can also see them crystals. This is the triple phosphate coffin lid appearing crystal, uric acid crystal, and this is a calcium oxalate envelope shaped calcium oxalate crystal, envelope shaped calcium oxalate crystals, okay. Now we'll see basically where do you see these casts, and then we'll see the entire system. First of all, I told you casts. Casts are exactly the formed elements of urine, okay. Formed elements in urine will be called as cast. Formed elements in the urine is called as casts, okay. Now guys, if you look at the casts per se, the casts are actually formed in the distal tubules and they basically damage the DCT. They damage the DCT and therefore casts are very dangerous. A few casts that you must know, first of all, I'll just write the names of these casts, okay. They are hyaline casts. They're seen in any condition of proteinuria. They're seen in any condition of proteinuria. It can be physiological or it can be pathological, okay. Pathological and nephrotic syndrome, pathological like nephrotic syndrome, and this will be like pregnancy or fever or dehydration, all of them will lead to hyaline casts, okay, hyaline casts. Sometimes the cast can have granules and hence the name granular casts. Seen in acute tubular necrosis and acute pyelonephritis, It can be also the RBC cast, very important, acute glomerulonephritis. The WBC cast can also be seen in the same condition, but it is mostly seen in acute pyelonephritis along with acute tubulo-interstitial nephritis, and finally there can be a broad cast. Broad cast is very importantly seen in chronic renal failure CRF. It is seen in chronic renal failure CRF, okay. These are various types of cast and the condition in which they are seen. Very important among them is all them, especially remember the hallmark finding of the RBC cast is acute glomerulonephritis, okay, acute glomerulonephritis, which also shows dysmorphic, RBCs. They also show dysmorphic RBCs, okay, dysmorphic RBCs. So having understood this, let's now move to the next topic, the basic type of glomerulonephritis. To understand this glomerulonephritis, we'll just have a quick revision of the structure of a glomerulus, okay. We'll have a quick revision of structure of a glomerulus. So look at this image, it's a normal glomerulus, okay, it's a normal glomerulus. So what are the normal glomerulus finding? See, these are all the tubules, okay, these are all the tubules, okay. Between tubules, this area can be called as interstitial area, this can be called as interstitial area, okay, they can be called as interstitial area, okay, interstitial area. Now the point is, what are these? These are all the glomerulus, okay, these are all the glomerulus. This is round thing is glomerulus, in which these small things are the capillaries, okay, these are the capillaries, okay. This pink area here is nothing but mesangium, okay, mesangium. The pink area here is a mesangium. So actually this entire glomerulus has a caprice which is on the mesangial area, and around them there are plenty of tubules with interstitial areas. Now guys, look at the glomerulus on the electron microscopy. On the electron microscopy, you can expect, what you can see here is, this is a mesangial area, it's a mesangium, okay, this is endothelium, and what you are noticing above the endothelium, if you look carefully, this is a podocyte, it's a podocyte. Now podocytes actually, if you look carefully, so look, this is endothelium, and above the endothelium this is the podocyte, and you can see the foot process of the podocytes. These all are the foot process of the podocytes, okay, and above that area there is a mesangial area, okay. That means what happens, the filtrate of the urine comes from the endothelium out, passes through foot process of the podocytes, and then comes into mesangium. Further, it then goes through the parietal cells of the glomerulus and starts forming the tubules and starts forming the tubule, okay, starts forming the tubule. This is how the normal glomerulus findings are. Now what may happen here is, suppose there is deposition of an immune complex or a granuloma, what happens, the entire glomerulus is getting inflamed, and that inflamed glomerulus is called as glomerulonephritis. Because of the inflamed glomerulus, what happens, the negative charge of the GBM is lost and the protein starts coming out into urine. Protein starts coming out in urine, and two types of finding can be seen, one is nephritic and one is the nephrotic syndrome, okay. So this means simply inflammation of glomerulus. Inflammation of glomerulus, it can cause nephritic syndrome or can lead to nephrotic syndrome, okay, nephritic or nephrotic syndrome. Now what you must remember here is the finding differences, like first difference is very important, proteinuria, then edema, hypertension, hematuria, and uremia, that is renal failure. Remember one thing, in the nephritic syndrome, less than 3.5 grams per day with a mild amount of edema, but severe hypertension, uremia, and hematuria. Nephrotic has more than 3.5 grams per day with severe edema, mild hypertension, hematuria, and uremia, okay. So these findings are must to know. And then comes, what are the causes of nephritic and what are the causes of nephrotic, okay. See, when you talk about the nephrotic causes, in the primary glomerular disease, nephritic is caused by PSGN, as you know, most common cause in children. It can be RPGN, okay. It can be MPGN, and it can be Iga nephropathy, okay. Similarly, when we talk about the nephrotic syndrome, the causes are minimal change disease, FSGS, MGN, and it can be again the same MPGN and Iga nephropathy. So we must know what are the common causes, like see, most common cause of children nephrotic syndrome in children, PSGN. Similarly, most common cause of nephrotic in children is minimal change disease, okay. The most common cause in adult is Iga nephropathy for nephritic. The most common cause of in adult of FSGS, and MGN is the most common cause in elderly. Above 60 years of age, MGN becomes more a common cause, okay. These are all the primary causes, but remember one thing, MPGN and Iga can present as both nephritic or nephrotic syndromes. Now as you understand guys, all the disease here will show you some or the other deposition in the glomerulus. Some of them deposit just below the podocytes. Podocyte is called as visceral epithelial cell, and therefore the deposition is called as subepithelial deposits. What I'll do is, I'll make a table of the immune complex deposits. A very quick revision for that, immune complex deposits. The sites and where they are seen, the sites and where they are seen. Okay, sites and where they are seen. Immune complex deposition, the sites. It can be subepithelial deposits, subendothelial deposits, mesangial deposits and mesangial deposits, and it can be intramembranous, okay, intramembranous deposit, okay, intramembranous deposits, intramembranous deposits. Okay, let's see how. Subepithelial deposits, it can be PSGN, okay, it can be RPGN, especially RPGN type 2, RPGN type 2, RPGN type 2, and it can be MGN. Subendothelial deposits, it is seen in MPGN type 1, SLE, that is lupus nephritis. Deposition in mesangium, it is usually seen in IgA nephropathy, and intramembranous is often seen in MPGN type 2, MPGN type 2, okay. But it is not a fixed rule, as you know that the PSGN deposition can be also seen in the mesangium and can also be seen in the subendothelial. So, I am telling you the most important deposition, okay, most important site of deposition are these in the diseases. These are very frequently asked as a question. Now, in the subsequent topics, we will talk about what is the basic morphological finding in the disease, because see, most of the disease here are treated by the same thing. Treatment for all of them is steroids, and if they are not responding, you can give cyclophosphamide and cyclosporin therapy or tacrolimus. That means you have to give immunosuppressive therapies for most of them. Therefore, what we need to know is basically the morphological differences between these two tumors, these all tumors, or not the tumors, the findings. We will start it one by one. In nephritic, I'll first talk about, the PSGN, okay, PSGN. So, it means post streptococcal glomerulonephritis, okay. Now, etiological agents, you all know these things, so I will just write in short. Group A, beta hemolytic streptococcus. The strains are 12, 4 and 1, okay, 12, 4 and 1. That is the PSGN, that is a PSGN, okay, PSGN, okay, it is about the PSGN. Now, guys, what is the morphological finding? This is very, very important. Morphology. Remember, whenever the question asked is on morphology, always remember these three headings: light microscopy, fluorescence microscopy, and the electron microscopic findings. Okay, three findings that you must know: light microscopy, fluorescence microscopy, and the electron microscopy. Okay, and the electron microscopy. The light microscopy, these shows endo and exo capillary proliferation. That means the neutrophils are both inside the capillary and also outside the capillary. The fluorescence microscopy, this shows the IgG and the IgM deposition, which shows granular deposits. They show granular deposits. These deposits, they also are called as starry sky appearance, and in the EM, suppose there is a podocyte, so deposition are seen below the podocytes like this. Deposition are seen below the podocytes, something like this, essay. These depositions are called as humps, HUMPS. These are called as humps. These depositions are called as humps. Okay, humps. Referred better to as subepithelial humps. Okay, subepithelial humps. Okay, subepithelial humps. Okay, subepithelial humps. The second disease we'll discuss is about the RPGN. RPGN. First of all, remember, they are those diseases which will cause any glomerulonephritis which is going to acute renal failure within the period of 6 weeks will be called as RPGN. It will be called as rapidly progressing, rapidly progressing glomerulonephritis, okay, glomerulonephritis, RPGN. Now, before we move to the morphology, classification becomes a very important part here. Classification, it can be RPGN1, can be RPGN2 or can be RPGN3, okay, RPGN1, 2 and 3. RPGN1, okay, RPGN1, it includes the anti-GBM disease, anti-GBM antibody disease called as Good-Pasture syndrome. Type 2 RPGN, the type 2 RPGN, which is the immune complex deposits, immune complex deposition. These include the various diseases like MPGN, MGN, Iga Nephropathy, HSP, Iga Nephropathy, Henoch-Schönlein purpura, also Fsgs. It can include SLE, infections. All of these will include the immune complex deposits. Okay. The type 3, remember, is paucimmune. The type 3 is paucimmune. The paucimmune means 3 diseases will be included. 3 disease means it can be vaginous granulomatosis, it can be Churg-Strauss syndrome, and it can be microscopic polyangiitis. Okay, microscopic polyangiitis. Microscopic polyangiitis can be seen. Microscopic polyangiitis. So these classifications are very, very important, especially if you add the FM finding in these 3, it is even becoming more and more important. See why? If you look at the FM finding of these 3, the FM finding, that is fluorescent microscopy finding, here is linear deposits, okay, because this is antibody deposition. Here it is granular deposits, and here you do not see any deposition as such, because paucimmune, right? Paucimmune means less immune complex deposition. In fact, the deposition here is ANCA. Okay, this antibody deposition here is that of anti-neutrophil cytoplasmic antibody ANCA. Okay, they don't show any immune complex as such, only shows the ANCA deposition in the neutrophils, not in the glomerulus. Now, let's talk about the finding in the gross morphology and the light microscopy. So, we will talk about the RPGN morphology, and now it is common for all the 3. That means 1, 2 and 3 all will throw the same finding. In the gross morphology, if you remember, it is showing you flea, bitten, kidney. It shows flea, bitten, kidney. In the light microscopy, it shows crescents proportional to the poor prognosis. As the number of crescent increases, it is proportional to the poor prognosis. And on the EM, they all show rupture of GBM. They cause rupture of GBM, and therefore the patient rapidly is progressing to the acute renal failure. The patient rapidly progresses to the acute renal failure. The 3 things that you must remember in RPGN. Let's see the findings. So in RPGN, this is the PSGN assay. Look at the hump here. There is a starry sky appearance in the FM finding, and you see there is a neutrophil infiltration both in the capillaries and outside the capillaries, and hence the name endo and exo capillary proliferation. Okay, this one is what? It is hump. There is a porocyte, and below the porocyte there is a hump here. In RPGN, you can see there is a flea bitten kidney here, and this you see, this is a crescent. There is a crescent here, there is a crescent here also. Okay, there is a crescent. Okay, the findings is crescents and the flea bitten kidney. The next disease we'll discuss is Iga Nephropathy, also called as Berger disease. Remember one thing here, this disease is also called as mesangial proliferative glomerulonephritis. It's called as mesangial-proliferative glomerulonephritis. Okay, mesangial-proliferative glomerulonephritis is the name. Now, what is basically the Iga nephropathy? What exactly is the Iga nephropathy? This basically actually is due to the anti-Iga antibody or an increase in Iga due to celiac disease or severe liver disease. Okay, so etiology wise, it can be a celiac disease, it can be liver disease, or can be increase in Iga due to any cause, or can be anti-Iga antibody. This antibodies, that is Iga, remember this thing that they activate the alternate complement pathway, and that is the reason you find the deposition of C3 and the C3 nephritic factor, that is properdin, in mesangium along with Ig obviously in the mesangium. So remember one thing, as soon as you see the word mesangium, it straight away becomes the IJ nephropathy, C3 along with C3 nephrotic factor called as properdin, okay. The fourth one is MPGN. The name is mesangiocapillary glomerulonephritis or membranoproliferative glomerulonephritis. So actually MPGN means this one, MPGN, membranoproliferative glomerulonephritis. Now in this what you must remember is MPGN is of two types, MPGN is of MPGN 1 and 2. The finding that you must remember is MPGN 1 में the complement system activated is both classical and alternate, okay. It is both classical and alternate, okay. It's both classical system plus the alternate complements pathway. In MPGN 2 it is only the alternate pathway. Therefore the complement levels here, all complements are low. Here C1, C2 and C4 are normal. Because it will activate only the alternate pathway, you will see C1, C2 and C4 are normal. Now the biopsy finding, both of them have something in common, and the common thing is obviously look at the name, membranoproliferative. That means there is a proliferation of three things: GBM, mesangium and caprice. But what is the difference among them is the finding of 1 and 2. In 1 you see a duplicated GBM, you see duplication of GBM, a finding called as tram-track appearance, and in this you see the dense deposition in the GBM, and hence the name dense deposit disease, okay. You see dense deposit disease, okay, duplication of GBM in the type 1 and dense deposit disease in the type 2. If it is asked which of them has poor prognosis, type 2 has even more poor prognosis than the type 1. Both of them are steroid resistant, both of them recur in transplanted kidney, but prognosis of 2 is worse than 1, okay. Again repeat, prognosis of type 2 is worse than that of type 1. We now move to nephrotic syndrome, okay, nephrotic syndrome. The finding that you must remember here is proteinuria is very severe, proteinuria is heavy, more than 3.5 grams per day. Along with this heavy protein lost in urine, along with this heavy protein getting lost in urine, you also find some findings like you see, first protein lost in urine is the albumin, okay, albumin. The first protein lost in urine is the albumin, okay, albumin. Now after this there is a loss of transferrin, which leads to iron deficiency anemia. Similarly, the loss of other proteins can lead to hypothyroidism. It can lead to vitamin D deficiency. It can lead to thrombosis, and finally there is increase in fibrinogen from the liver. And when there is a loss of globulins, it causes infections. So what is important to understand is, even though all the proteins are decreasing because they are lost in urine, fibrinogen is because of the increase from the liver synthesis. As you know, it is an acute phase reactant, they will increase. All other are reducing, but the fibrinogen will increase, okay, and that is what is a very frequently asked question in nephrotic syndrome. We will take the findings one by one. Let us start with the minimal change disease, okay. The first one is minimal change disease. See, minimal change disease में in the morphology you must remember light microscopy you see no finding, fluorescent microscopy no finding. In the electron microscopy you see something called as effacement of the foot process of the podocyte, effacement of foot process of the podocytes. This unique finding is called as podocytopathy. This unique finding is called as podocytopathy. It is recently asked where else you see the podocytopathy. The answer is you can see this in MGN, obviously, Fsgs. You can also see this in the diabetic nephropathy. You also see this in diabetic nephropathy. But remember, in these others, you will find this with the some LM or the FM finding. So, if you see podocytopathy in the absence of LM or EM, LM or FM, it becomes minimal change disease. It becomes minimal change disease. Okay, this is all about the minimal change disease. Let's see this minimal change disease. The minimal change disease, as you can see, the light microscopy is completely normal. It's completely normal light microscopy with no neutrophil infiltration and nothing. You see this EM finding. In the EM, these are the foot process, okay, the foot process here, and these are the foot process again, this is the normal finding. When you look at this below, look at the effacement of the foot process, the effacement foot process, okay, effaced foot process you see in minimal change disease, okay, minimal change disease. The next one we'll take here is about the MGN, okay, second is MGN, called as membranous glomerulonephritis, okay, membranous glomerulonephritis is MGN, okay, MGN. Now, what about MGN that you should know? What is about the MGN that you should know? Dekho, MGN basically, the etiology is mostly primary or it can be secondary. Secondary can be tumors, it can be drugs, it can be infections, it can be paranephrotic syndrome of the other tumors. In primary, remember they have a typical antibody called as anti-phospholipase A2 antibody. This typical antibody you must remember in MGN. Morphologically, you will see light microscopy, fluorescence and the EM finding. The LM finding will show you GBM thickening and hence the name membranous. Now, in this GBM thickening, because of the subepithelial deposits, often you see this as a staining pattern you see as spike and dome appearance, In the FM you see granular deposits, and in the EM you see the podocytopathy along with the subepithelial deposits of the immune complex. So, if you see a podocytopathy without any other finding in the LM-EM, LM-FM, it becomes minimal change. But if you see the same thing with a spike dome appearance in the LM light microscopy, it then becomes the membranous glomerulonephritis, okay. The third one is FSGS, name is focal segmental glomerulonephritis, okay, glomerulosclerosis, not nephritis, glomerulosclerosis, FSGS is the name, not FSGN. Remember, the etiology is very important here, okay, the etiology of this thing is very important. So, why it is important? Because the etiology of this finding, most common etiology is reflux nephropathy, most common etiology is reflux nephropathy. This is the most common etiology, okay, most common etiology is reflux nephropathy, okay. It can be hypertension, okay, it can be hypertension nephropathy, it can be sickle cell anemia, okay, it can be sickle cell anemia, it can be massive obesity, in fact, it can be intravenous drug abusers or can be renal surgery. But among them, remember the most common and the most important is reflux nephropathy. In the morphology, look at the name, in the LM, FM and the EM finding. See, it is focal segmental glomulosclerosis. But is the fibrosis or sclerosis? This sclerosis means fibrosis, right? We will see fibrosis, right? This means fibrosis. Is it everywhere? No, it is focal and segmental. That means if you are seeing say 10 or 15 glomerulus in a kidney biopsy, it is seen in fibrosis in less than 50% of the glomeruli involving a part of glomerulus. Not the entire glomerulus is involved, only the part of the glomerulus is involved. So, two things are important, less than 50% and part. Less than 50% and the part. The fluorescent microscopy finding, the FM finding, you can expect here in the Fsgs is the granular deposits. This may be IgM or can be IgG along with obviously C3 deposits. Okay. The EM, again if you remember, it shows podocytopathy. It shows podocytopathy along with immune complex deposition, okay, plus the deposits, immune complex deposits. This is the main finding you expect in FSGS. Remember one thing, in HIV, you find a type of FSGS called as collapsing variety of FSGS. Okay, you see collapsing variety of FSGS. Why collapsing? Because in this variety what happens, the entire tuft collapses, and along with the collapse of the tuft collapse, you see proliferation of podocytes, Along with the tuft collapse, you see proliferation of the podocytes. Okay, it is seen in the HIV. Okay, it is seen in the HIV. Okay, it is seen in the HIV. Next comes congenital nephrotic syndrome. Okay, congenital nephrotic syndrome. Now, what do you need to know here? See, in the this suppose a podocyte, it's a podocyte here. So, podocytes are lying on what? On the GBM. They are lying on the GBM. Remember, the podocytes are linked with each other, the foot process are linked by each other by some proteins. These proteins, they join the podocyte foot process so that the linkage is very strong, and when the fluid is coming out, it will not disrupt the entire podocytes. Accordingly, this protein is called as nephrin, and this one is called as podosin. If any of these two proteins are lost, it will lead to congenital nephrotic syndrome. Okay, what you must remember is among them what is more common? Answer is nephrin. Okay, so we'll just make a small table with the gene name, protein name, the protein name, their gene name, and what are the findings that you must know. See, protein mein, first protein is, as you see, is nephrin, NPHS. Okay, gene name is NPHS. Gene name is NPHS1. Clinically, it shows minimal change disease, Okay, clinically it shows minimal change disease, Okay, minimal change disease. This is the most common gene defect. It is the most common gene defect. It has a good prognosis and is also called as Finnish type with double N, Finnish type, also called as Finnish type. Podosin, gene name NPHS2, and shows FSGS morphology. Okay, this case is completely steroid resistant. This is partially steroid resistant. it's partially steroid resistant, but NPHS2 is completely steroid resistant. Okay, it's completely steroid resistant. Okay, so these two proteins are very important, nephrin and the podosin. Okay, it is called as congenital nephrotic syndrome. Similarly, there is something called as Alport syndrome. Alport's syndrome. Okay, there is a fifth one, Alport syndrome. Why the fifth one? The first one was minimal change. Second one was MGN. Third, Fsgs. Fourth, congenital. Fifth one is Alport syndrome, also called as hereditary nephritis. Now, what you must know here is, first of all, the triad. It includes a triad of three things. First one is obviously the proteinuria and hematuria. Proteinuria and hematuria. Okay, proteinuria, hematuria. It then also includes the bilateral sensory neural hearing loss, and it causes anterior lenticonus. And why is this happening? Because it's very important. The pathogenesis is not immune complex, it is defective collagen 4, mostly alpha 5. It's a X-linked dominant pattern of inheritance. X-linked dominant pattern of inheritance. Okay. Now, in this, the morphology again becomes a bit important, because in the light microscopy you see a diffuse GBM thinning. Why? Because the GBM is composed of collagen 4, but you see the same thing on the EM, the GBM is splitting out. Because this is a GBM, because of defective collagen, splits out like this. Splitting of GBM is seen. The splitting of GBM is better called as basket weave appearance. Splitting of GBM is better called as basket weave appearance. Basket weave appearance. Okay, it's better called as basket weave appearance. Okay, basket weave appearance. Okay, basket weave appearance. So this is the Fsgs. As you see, this part is closed. Of the three glomerulus, only one of them is closed, so becomes focal. And because only part of this glomerulus is closed, and hence becomes segmental, so it called as focal segmental glomerulosclerosis. FSGS, focal segmental glomerulosclerosis, right? In Iga nephropathy, look at this. There is a deposition in the mesangial area. This is the mesangial deposition. And you can see this is the IgA and the C3 deposition, where in the mesangial area. In the mesangial area, it becomes the IgA nephropathy. Now, this is the typical basket weave appearance. Look at this splitting of the GBM here. This part is showing you splitting of GBM. It is called as basket weave appearance. It is not seen in IgA nephropathy. This is completely, this is no wrong. Please, this is not seen in IgA nephropathy. It is seen in Alport syndrome. Okay, Alport syndrome. Okay, it is seen in Alport's syndrome, not in the IgA nephropathy, right? Now we move to the diabetic nephropathy. Okay, the next one is secondary diseases. Okay, we now move to the secondary glomerular disease. Secondary glomerular disease. In this, the one thing we'll discuss is diabetic nephropathy. Diabetic nephropathy. Okay, diabetic nephropathy. Okay, diabetic nephropathy. Now, in diabetic nephropathy, you must first know what exactly is the screening test. The test we use for screening is microalbuminuria. Now, this is defined as a range of 30 to 300 milligram of protein or albumin passing in 24 hours of urine. This range is called as microalbuminuria. This range is called as microalbuminuria. Okay, this range is called as microalbuminuria. Now, if you look at the finding or the morphology in the kidney, you must differentiate into three headings. One, in the gross morphology, then in the light microscopy. In grossly you see granular contracted kidney, often seen in both the kidneys and hence bilateral. Some books call this symmetric, some books call this symmetric, okay, some books will call this symmetric, okay, symmetric. In the microscopic finding, you see the finding can be distributed in the form of glomerular finding, glomerulus finding, okay, finding in the glomerulus, finding in the glomerulus, finding in the tubules, okay. First of all, look at the finding in the glomerulus. In the glomerulus, 5 findings are seen. Number 1, diffuse GBM thickening. Remember, even though it is thickened, still it is damaged and hence becomes permeable, more permeable and more permeable. This is a cause of proteinuria occurring in diabetes, cause of proteinuria occurring in diabetes, okay, cause of proteinuria occurring in diabetes. Second is diffuse mesangial proliferation. Ultimately, the mesangial cells keep on proliferating to become a nodule and hence the name nodular glomerulosclerosis. This is referred to as Kimmel-Steel Wilson nodule, which becomes the most specific finding of diabetes, okay, nodule. This becomes the most specific finding of diabetes, okay, this is the most specific finding of diabetes, Kimmel-Steel Wilson nodule. Some textbook also call this nodule to be between the capillaries and hence the name intercapillary glomerulosclerosis, okay. Some books call this nodular, also referred to as intercapillary glomerulosclerosis. The fourth one is fibrin caps, and fifth one is capsular drops, okay, fibrin caps and capsular drops, fibrin caps and the capsular drops, okay. These 5 findings are there in diabetes, among which these 2 are the most common finding, and specific finding is the Kimmel-Steel Wilson lesion, Kimmel-Steel Wilson lesion, Kimmel-Steel Wilson lesion. So look at the diabetic nephropathy, So this is the Kimmel-Steel Wilson lesion, this big nodule here. It's in the glomerulus, you see the glomerulus, and this lesion, this nodule is a Kimmel-Steel Wilson lesion nodule, and these are looking so dark red because they are actually PAS positive. What is PAS? Periodic acid shift, PAS positive. There is a nodule here, and these are the diffuse proliferation of the mesangium, diffuse lesion and the nodular lesion. Both of them are seen in diabetes. If I ask you what is more specific, nodule. If I ask you what is more common, diffuse. Okay, these all findings are seen in the glomerulus. Let's now see what are the findings you expect. What finding you expect in the tubules? So in tubules, you expect glycogen deposits, in the proximal tubules referred to as Armani-Epstein crystals. Okay, Armani-Epstein crystals. Armani-Epstein crystals are seen in the tubules of the diabetic nephropathy cases. Okay. Now in the SLE, so second one in secondary causes in SLE, also called as lupus nephritis. Remember, all types of immune complex can be seen. That means it can involve IgA, IgG, IgD, IgE. It can also involve lambda and the kappa chain, and hence this typical deposition is referred to as full house effect. Full house effect is seen. Why? because you see deposition of all the types of immune complex deposits in the glomerulus, and hence the name full house effect is seen. Okay, full house effect is seen was a recently asked question in the AIIMS exam. Okay. Finally, from this we now move to the finding in the tubules and the interstitium. What I am trying to say is, till now our main concern of discussion was in the glomerulus. Okay. Now from the glomerulus, let's move to the tubules and the interstitium. We will divide this finding into acute and the chronic tubulo-interstitial nephritis, one type of which is called as pyelonephritis. So from the finding of glomerulus, we will now move to finding of tubules and interstitium. Okay. The disease is called as, next main topic is tubulo-interstitial nephritis. Okay, tubulo-interstitial nephritis, tubulo-interstitial nephritis. Okay, tubulo-interstitial nephritis. Now see, it is basically the disease or the involvement of the tubules and interstitium, that means inflammation of tubules and interstitium is called as tubulo-interstitial nephritis, one type of which is pyelonephritis. Okay. Now this involves tubules, this tubule, this interstitium, plus it also involves renal pelvis, which can be of two types, can be acute or can be chronic. Often what you must know here is, what is the morphological finding in the acute and the chronic pyelonephritis. Let's start the morphology first. Morphologically, in acute you just see the abscess and the pus formation, the abscess and pus in kidney. However, in chronic you find a typical finding called as, again, the bilateral or unilateral, it depends upon what is the etiology. So it can be called as asymmetric, unilateral, granular, contracted kidney. Okay. In the microscopy, look, in acute what you expect is the obvious thing. You expect what? Edema and neutrophils. You find edema and neutrophils. Okay. But in the chronic you do not find edema, you find fibrosis, you find interstitial fibrosis. This collagen can also be around the glomerulus, and hence a very frequently asked question, periglomerular fibrosis. If it involves the vessels, if this involves the vessels, it can lead to hyaline arteriolosclerosis. So if it involves the vessel, it can lead to hyaline arteriolosclerosis. Okay. It may lead to Fsgs, but very importantly, if it shows deposition of the colloid like substance in the tubules, the finding we name it as thyroidization of tubules. Okay, thyroidization of tubules. Okay, thyroidization of tubules. Okay. Now the complications are again very important. I'll just name them. Complication of this acute is 3P, and complication of chronic is called as xanthogranulomatous pyelonephritis. Xanthogranulomatous pyelonephritis. Okay. The complication of acute is papillary necrosis, pyonephrosis, and perinephric abscess. Okay, perinephric abscess. So this table itself is very important. I always said in the class is one of the very important table, and especially this finding thyroidization of tubules. Thyroidization of tubules. So look at this finding here. This is the glomerulus, and if you look at the tubules here, these are tubules here you see here. The tubules you see here, these all tubules are filled with colloids. These tubules are filled with colloids. These all tubules are filled with colloids, and hence the name thyroidization of tubules, thyroidization of the tubules. Okay, this is about the tubulo-interstitial diseases. We now move to the last topic, that is the tumors. Okay, renal tumors. Renal tumors. Renal tumors. Etiology you all know is smoking. Most common etiology being smoking. Most common etiology being smoking. But apart from smoking, it can be petroleum products. Petroleum products. Okay, petroleum products. It can be the asbestosis. In fact, can be OCPs. Sometimes a massive obesity because of high estrogen levels. Massive obesity. The hypertensive change of the kidney. So, chronic hypertension. Chronic hypertension. Okay, chronic hypertension. Now, the findings that you expect in this renal tumors, it all depends upon the clinical features. That means it will always show a triad of paleness hematuria, okay, paleness hematuria, abdominal mass plus loin pain, okay, loin pain. Three things you see in the renal failure. Talk about the renal cell carcinoma, RCC. Okay, RCC. RCC, it has two findings, various type of morphology, like it can be clear cell carcinoma, okay, clear cell carcinoma, it can be papillary cell carcinoma, okay, papillary cell carcinoma, okay, clear cell carcinoma and the papillary cell carcinoma. See, the clear cell carcinoma, first of all you must know that the clear cell carcinoma and the papillary cell carcinoma have different origin. They both are originating in the tubules, clear cell in the PCT, papillary in the DCT. Gene mutations in the clear cell is VHL gene and the papillary cell carcinoma has a MET gene mutation, MET gene mutation, okay, MET gene mutations. The chromosome mutations, it is chromosome number 3 mutation in the clear cell, it is trisomy of 7, 17 and loss of Y in papillary, loss of Y in the papillary cell carcinoma, okay, loss of Y in the papillary cell carcinoma, okay, loss of Y in the papillary cell carcinomas. Okay, loss of Y in the papillary cell carcinomas. Now guys, what is the morphology? Morphologically, the clear cell, if you look at this tubule here, the tubules, like hey, the tubules normally have what? The tubules normally, if you see, they have the PCT cells or the DCT cells here. So the nucleus is in here. This is a normal tubule. Okay, this what drawn is normal tubule. But here you will find the clear cells inside the tubules and hence the name clear cell carcinoma. The clear cell is because they have vacuoles. They have vacuoles at this part. And hence the name clear cell carcinoma, okay, clear cell carcinoma. In papillary, this tubule, it becomes papillary in shape like this. The tubules itself become papillary in shape and they will have the cells at the periphery with the macrophages, that is the foamy cells at the center like this, some foamy cells at the center like this. Now, because of the papillary shape, they are called as papillary cell carcinoma, because of the papillary shape they are called as papillary cell carcinoma, okay, they were called as papillary cell carcinomas, right. So, this one is clear cell, this one is papillary cell carcinoma. As you see, which of them are looking dark? The papillary is looking very dark in color and hence some books are calling this chromophilic, okay, the name is chromophilic variety. Papillary cell is also referred to as chromophilic variety, okay. Now, this clear cell cancer having a VHL mutation was also this AIIMS question this year. The other varieties, the other variety that you must know, the third one is chromophobic variety, okay, chromophobic variety. It can be Bellini duct carcinoma, Bellini duct carcinoma, It can be XP11 translocation variety, a new variety, XP11 translocation variety, and very rarely but can be seen is Meldry variety. This variety is seen in sickle cell anemia. Okay, it is seen in sickle cell anemia, and this has the poorest prognosis. Remember, this has the poorest prognosis. Chromophobic has the best prognosis. Chromophobic has the best prognosis. Medullary cancer has the poorest prognosis among all of them. Among the bladder carcinoma, they again etiology is most commonly etiology is smoking. They can also be due to the benzidine dyes, okay, they are also due to benzidine dyes, okay, cyclophosphamide drug, and they can be seen as a result of schistosomiasis. What is important to know is, look, mutation wise they show the HRAS mutation and chromosome number 9 deletion. But what is important to know is, morphologically, if you know that bladder cancer is mostly transitional cell cancer, it is transitional cell carcinoma more than squamous cell carcinoma. However, this schistosomiasis mainly causes squamous cell carcinoma. I am not saying this will not cause transitional, but this variety which is due to schistosomiasis is mostly the squamous cell carcinoma, Okay. So, these are all the findings that you must know and see. Let us talk about this renal tumors. This renal tumor, this is a kidney and with a mass at the upper pole of the kidney. So, when the biopsy was taken on this big mass of the kidney, it may show the clear cell variety. Look at the clear cells, white in color. The clear cells are there because they contain the lipids and the vacuoles, and hence the name clear cell carcinoma. Sometimes they show this papillary variety. Look at the papillary variety, look at the sphincter-like projections. They become the papillary cell carcinoma, And sometimes you see they show this, you see this nucleus and there is a white halo around it, this halo. This perinuclear halo is seen in this variety called as chromophobic variety. So, clear cell variety, papillary cell carcinoma, and the chromophobic variety can be seen in a renal cell carcinomas. Again, you know, this is very important topic. Kidney will definitely give you at least 3 to 4 questions in any exam that you appear. Okay.